We'll go to the next speaker. Multimodal imaging for ocular surface tumors, Dr. Puneet Jain.
Thank you so much, and thank you, the LOC, for making me a part of this session. So let's let's begin with the presentation. So before we move on, one should remember that if you have access to fancy things, you should not leave the basic things behind. So a detailed slit lamp examination and vital staining in tumors takes precedence over any imaging tool, and one should not jump to these imaging tools, which I'm going to talk about subsequently. So ocular oncology has come a long way in last 3 decades. There has been a huge expansion in spectrum of ocular surface diseases, tumors, and our understanding of it. Alongside, there has been an evolution in anterior segment imaging as well. That could be a good slit lamp photograph or an ASOCT, and subsequently other investigations. The non-invasive nature of these imaging techniques has led to their acceptance on a very large scale, and also the increased availability. So there was a time when an anterior segment OCT would be available at select places, if I talk about Delhi, and now almost every setup would have one basic OCT, and if you attach an anterior segment attachment to a posterior OCT, you can get a good ASOCT as well. So there's a huge spectrum of ocular surface tumors, and many of these can be differentiated amongst themselves using these imaging techniques. So what is the implication of using? Is it just diagnostic? No. So obviously they are a diagnostic aid, that is why they are used, but they also decrease the reliance of an ocular oncologist on excision or incision biopsy. So prior, whatever was clinically indeterminate was probably biopsied, but now having an understanding of these imaging tools allows us to have a little more freedom, wherein we can observe for serial changes 6 weekly, 3 monthly, before we decide on taking any surgical decision, especially if our pointer is towards a benign lesion. Also, they help in therapeutic decision making if we are planning to manage the case non-surgically, and also at the same time monitor the therapeutic response. That said, histopathological examination still continues to be the gold standard of care for ocular surface tumors, and imaging are just the adjuncts to arriving at a tumor. So that should be very clear. The current armamentarium, there are 4 such investigations. One is the ASOCT, then the ultrasound biomicroscopy. IVCM is not commonly used, and recently OCTA has been used, but there are no characteristic feature of OCTA which would help one to diagnose tumors. So this is still in infancy, but I'm sure in times to come this will also be a handy tool. So anterior segment OCT has evolved itself from a time domain OCT to a spectral domain OCT. So when I was in my JRship, we mostly had time domain OCTs, and now everywhere we have much better generations of OCT. So what did this do? This led to better resolution of images, which was very important for imaging surface tumors. Now even with the newer resolution OCTs, with newer generation OCTs, the resolution is even better. So just to give you perspective, the axial resolution of a time domain OCT is just 18 microns, whereas that of an ultra high resolution OCT is 5 microns. That makes a lot of difference. And also that these are non-contact procedures compared to the others, so they are very patient friendly. Coming to the most common ocular surface tumor that we come across, ocular surface cumulus neoplasia. So Carol Karp and group have described the classical high resolution OCT findings of an OSSN. So this is something that is a common knowledge when it comes to the ocular oncology circle. So you see, when you take a section through the lesion, you see that the corneal epithelium abrupt transition to an hypertrophic, to a thickened hyper-reflective epithelium. This is the characteristic feature. Sometimes you can see this lucid zone between the tumor and, as you can see in this patient, between the sclera. That is also a important finding. So these preoperative changes beautifully correlate with the histopathological findings if you were to biopsy the patient or treat the patient surgically. They also help differentiate between the various benign masquerades. Obviously, this is a characteristic case, but in clinically indeterminate cases that can be very useful. They are very handy in managing response when treated with topical immuno or chemotherapy. With treatment, there is reduction in epithelial thickness as well as the hyperreflectivity. So let's take a case. So this case was referred as query corneal plaque, query OSSN to my OPD. I did a rose Bengal stain. It was apparently negative. The limbus and conjunctiva was clear. So I would not start this patient on interferon therapy. There is enough doubt in my mind what to do. So I did an ASOCT. The ASOCT was also kind of unequivocal, though there was some increased thickness of the epithelium, but there was no abrupt transition as such. So I decided to have a close observation on this case, and I called the patient at 6 weeks. Now at 6 weeks, you see there's a beautifully delineated lesion with the corkscrew vessels and intrinsic vascularity. I did an OCT for this patient. Now you see all the characteristic findings, but you see that the epithelium is not that hyperreflective, probably because the lesion is very, very thin, right? So this is how these investigations help us. So the patient was started on topical immunotherapy as per the standard protocol, and this is how the patient was at 1 month of age, 1 month post treatment. So you see that the epithelium is back to normal, and the hyperreflectivity, whatever subtle hyperreflectivity was there, is also gone. So this is how the patient presented. This is how the patient was at the first follow-up, that is 6 weeks, and this is how the patient was post-therapy. So these so if this was in an era of absent ASOCT, probably I would have called the patient after 3 months or 6 months and not that close interval, because I would not be able to determine the change in the lesion. So what is the point of calling the patient at such short intervals? So this is how the resolution was on ASOCT. So what are the limitations of ASOCT? Okay, I'm running out of time. All right. So leukoplakic OSSN, there will be shadowing, a thick pigmented OSS, there will be shadowing. So just to give you perspective, if a lesion is more than 465 microns thick, you will have shadowing on ASOCT. This is how shadowing looks, leukoplakic OSS, and you really cannot see behind the lesion whether there is an intraocular invasion or not. So you would require further imaging in this, wherein the role of UBM comes into play. So UBM can be 50 megahertz or 20 megahertz. The 50 megahertz one has a better resolution of lesions, but less penetration, and the other one has obviously deeper penetration. So the role of UBM is in shadowing. The role of UBM is also very important in recurrent OSSN, where an ASOCT will not give you a good image. So accurate depth assessment in such lesions has to be done with the help of a UBM. So there are characteristic UBM findings. So we'll not go into the details. If there is intraocular invasion, then what should you look for? So anterior chamberal blunting would be the first sign. There could be frank angle infiltration. There could be increase in the thickness of the ciliary body or the entire uvea in that region. There could be gross intraocular invasion. Limitations of UBM is obviously that's a lower resolution tool. So you would not do a UBM in a thin tumor. An ASOCT does better when there is no shadowing. It is a contact procedure. Whoever is doing the UBM requires a lot of training. The patient has to be under a water bath for some time, so patient cooperation can be poor, and UM is not that frequently available. Even in Delhi, there are very few setups, government and private included, which have UBM. So this is one article. If there is anybody young who wants to pursue oncology or is doing oncology, this is a good article to familiarize yourself with how a UBM finding, how a novel UBM is. This is how angle blunting looks, just to give you some perspective. This is how an angle blunting looks on a UBM. So coming to the last bit, so this lesion was referred to me for conjunctival melanoma based on this dilated blood vessel, which was being called as a feeder vessel, which is controversial. But if you see closely, there are cysts in this lesion. So these presence of these intralesional cysts is a giveaway for nevus, and if you have ASOCT, you can take a image through the lesion, and you can document these, and you can send the patient home for a 6-monthly follow-up. And if the patient is cosmetic inclined, obviously in this case, it's a large nevus, you can remove it. So just wrapping up, couple of more slides. So an HR-OCT would also help differentiate between a melanoma and a pigmented OSSN and vice versa. So an OSSN versus a apigmented amelanotic melanoma. So remember that these are not epithelial lesions, so the subepithelial tissue will be hyperreflective in these cases, and most of these melanomas tend to be very thick, so you would need a UBM to rule out intraocular invasion. ASOCT will fall flat when it comes to diagnosing a melanoma. Just a bit about lymphoma. So a very typical picture of how a lymphoma would look in ASOCT if you were to image it. Most of the lymphomas are large when they present to us and would require imaging in the form of CT or MRI. But if you do come across a lesion that you cannot differentiate between a benign reactive lymphoid hyperplasia and a lymphoma, the epithelium is normal in both, but the characteristic feature of BRLH is high variable hyperreflectivity. That is because of the infiltrates that you see, the pattern of infiltrates that you see on biopsy. So this is an important point that would help you distinguish between the two as well. Ray, thank you so much.
Thank you, Dr. Puneet. That was a good insight into the use of ASOCT. Actually, we all had observed that ASOCT is much useful and much practical than UBM. Most of us, actually some of us get trained to do it, but at the end we keep it aside and use the ASOCT.
Right.
Okay, any inputs on the use of ASOCT in limbal dermoids, the depth, the grades, and when do you go in and, you know?
See, if the limbal dermoid is, so we're talking about the corneal part, right?
Yes.
So you have to take a decision whether you can operate yourself or you do need a patch graft or a help of a cornea specialist or your colleague. You usually see a lot of shadowing on dermoids as well. So it is very difficult. So if you are not sure what is the exact depth of the lesion, you might as
No,
well
will
keep.
ASOCT, because see, it's a child, it's going to -9 diopters of astigmatism,
Right.
then we have to go in.
So it does
Straight
help, but see, when these lesions, if the child is presenting early, like let's say within 5 years of age, and if you can get a good ASOCT image, it will definitely help you. But if the child is presenting in adolescence, there are already a lot of changes that have happened over the lesion. So there might be some calcification, all those things. In those cases, your ASOCT will not work. So
And
UVM would still be my preferred choice if it is a larger dermoid causing that much astigmatism.
Yeah, and I had another situation where we removed it. There is a large pseudopterygium now. So then it is looking little doubtful after a few months, like whether ASOCT will give me an insight into
No.
what's
Fibrosis, once you have operated and then you are trying to image something, it will just show fibrosis. Fibrosis has no typical features on ASOCT. So it will just look like a thickened epithelium. That is what the problem is in recurrent tumors which are not operated. So you don't have a biopsy report and the patient comes back to you and the
whether ASOCT will help us in like knowing, because it's showing some surface changes now, whether, you know,
see,
should I
if you're sure of the diagnosis it's a dermoid, then you really don't need to worry about anything else. You just have to make the ocular surface right. There will be a big Dellen if you remove. So that
Okay.
all these things you have to
the
anticipate.
child is doing fine, it has come down from -9 to -3 now, I think.
So when did you operate? At what age did you operate the child?
At 2 years of age.
Okay. So there's another fun fact. The thing that if you operate the child beyond 10, the astigmatism will not go. Even if you remove the lesion, the astigmatism will not go. So the astigmatism will respond if you operate the child early, but imaging techniques in these cases
Yeah.
would not be that handy.
Okay, thank you.
Yes, sir, please.
Thank you.
Your experience on situations where it's been biopsy, excision and so on, have you re-reviewed your radiology findings to see, especially in pigmented lesions and OSS? Has there been a difference once you have cases of pathology?
So
Have you re-reviewed your radiological and seen something different?
no. So sir, it's like that. So if I am biopsying a lesion, the current rule in oncology is to do excision biopsy wherever possible. That is the first point. So you were talking about incision biopsy. Incision biopsy, only scenario would be a large melanotic lesion in which I cannot see a posterior border, so I am biopsying it with the diagnosis of melanoma in mind. In such cases, I would not be even tempted to correlate my histopathology with my imaging techniques. My focus would be on metastasis. So are you getting my point? So there has not been a situation yet where I have to go back to my imaging. So there has not been a situation. See, I have about 7 years of experience. I'm still young in oncology, but I haven't had the need to go to an ASOCT or a UVM back to relate it with my histopathology. It can be other way around. I mean, so I am having a purple patch. I haven't yet come across
I
a
think
tumor like that. Yeah, it's an
I think
absolutely
this is a
valid
good
question, sir.
food for thought. Like we can go back and do
Yeah.
a study
So-
on this. Hello, hello.
Yeah, so surface tumors tend to be simple. Right. Yes, ma'am. Ma'am, I am not aware of any protocol for frozen sections for ocular surface tumors per se, but this no-touch technique, which, as described by Shield, says that if you have an excisable lesion, you take a 4 millimeter clinically clear margin, and then you do edge cryotherapy to the tumor-free end. That makes it a 8 millimeter clinically clear margin. So, role of frozen sections in ocular surface tumors, not sure.